يقدر يسوي هذا الحين. 1 2 طيب الا طالع بس ابغاه وان سكرين ما ابغاه السايد هذا. السلام عليكم. لا يكفي. I'd like to introduce myself, Sahal Misfer. I've been at KKESH maybe for a few years. Today we'll speak about leukocoria. The term is known to all of you. When we started as a medical student and then become a resident, we face big difficulties to find resource for knowledge. There was no internet. I mean, there's no soft copy of the books. Nowadays, all the knowledge is accessible. Anyone who is maybe in the high school, he could access any soft copy of any book as a PDF from the online system, either by purchasing, direct purchasing, or he'll find the fake copies. He could access it and have it in his laptop or handheld tools or media. I think you are very lucky nowadays. You could access the knowledge very easily, and you could have soft copies of any textbook without difficulties, and you may not need to pay money even. There is a lot of website where you could access it and they will give you the copies free. These copies are not maybe legal copies, but as long as you use it within the country, there will be no problem. But if you carry your laptop or your media with you abroad and they will inspect it and find the fake copies, they may put you or give you penalties. Dr. Amru, Professor Sahal Amru, I know it's known for all of you. When I was rotating with him, he was trying to attend one lecture. He told me, don't attend the lecture, everything in the box. And this is true. I mean, nowadays we have a lot of series of lectures, and each one of you is mandatory to attend. But I think in the future there will be a new system where you could attend the lecture or through the online system, and you need just to approve that you attend the lecture or you listen to the lecture, and you may go through a short text of exam or just MCQs, and you will be counted that you attend. You could attend it. No need to stay in the audience. You may need to just attend online. And this could be an international system. There is a lot of university in the North America nowadays. They're just trying to get rid of the student in the campus and just put it online. They can just come and sit for the exam, interact with the lecturer, but they didn't need to come daily basis, driving, sitting in the audience, and I think this system is going to be the future. Today we'll speak about leukocoria. Any one of you could find a lot of knowledge more than what I presented today in the textbooks. But what I would like to guide you is to how to be sure that you are not missing the diagnosis. Leukocoria, leuko is white and coria is pupil, or like multipolycoria, ectocoria, and these things. It's just the pupil is the coria. And when you have a patient presented to you in the clinic and the ER with the leukocoria, you have to, usually are talking about children, we're not talking about adults. And so when it is the vision of the parents, if they are seeing or not, if whether one of them is blind or lost eye or is one eye parent, Be sure about there is consanguinities and prenatal history, postnatal history. All these guidelines all these important points will give you a clue sometimes to the diagnosis before you examine the child. History of a trauma, and you have to be sure that the patient was not sustaining. Sometimes the parents will bring the child to you with total hypemia, but they didn't have any history. What's happening? They didn't know what's happened. Maybe the child was hit by something, and he couldn't give the good answer to his parent or to you. Parent examination. If you think that there is a need to examine the parents, please don't hesitate to examine them. Don't feel shy to look at the eyes of the parents. Be sure that they have good vision and there's no ocular abnormalities. And once they have ocular abnormalities, this will give you some clues in your examination. The patient, you need to have a good examination, and if you can find that the child is difficult to be examined and you cannot examine the patient and you feel embarrassed, in front of the parents, don't hesitate to put the patient for sedation exam or examination under anesthesia to be sure that the child received appropriate evaluation. Vision assessment, this is one of the essential points. All of you are aware of that. Intraocular pressure is indicated in some cases. You didn't need to struggle with the child to know the IOP. If you feel that the cornea looks clear, the child is not photophobic, the cornea size is within normal, you could just gently put your finger on the lids and try to estimate the tactile estimation. If the child cope, that would be cool. If he didn't cope, no need to bother yourself with IOP, except if the patient sedated or under GA. Alignment. You have to know if the patient has nystagmus. Is it unilateral nystagmus or bilateral nystagmus? And is the patient strabismic? If the family notices strabismus or they notice just leukochoria first. If the patient aware of the leukochoria, sometimes the patient is presented to you, but the family, they didn't know that there is a leukochoria. They just think that the eye is normal. But when you examine the child, you will find that there's a problem. Slit lamp examination is essential. And fundus examination. Fundus examination, if the child has clear media, you could examine the fundus easily. But if their media is not clear, you have to use B scan. And if you have the B scan, you will be able to know if there is an abnormality within the posterior pole. The B scan is accessible and it's available and very useful tool. I was trying to recommend to the ER at King Khalid Specialist Hospital to have a B scan to be used by the residents. Still, I believe that it is essential, but when I asked Mr. Abdurrahman Hamad, he told me that they already provided a B scan to the ER for some times, but they noticed that the resident, they are not using the B scan at all. I know that they will not need it, except in certain cases. Cases with maybe endophthalmitis, leukochoria. For this reason, maybe the machine stay for 1 week not used by the resident. For this reason, they decided to move the machine. But I think that a B scan in the AR is indicated. Sometimes you didn't need to wait for the ultrasound technician to do it. All of you have been rotating with ultrasound. And each one of you should have the skills to do ultrasound. It's a very simple way to do it. It's not a big deal. And ophthalmologists, when they do it, the B scan, I'm sure they are more superior than ultrasound technician because they know what to do. They know what they are looking for. The ultrasound technician, he has some basic teaching. He knows what is normal, what's not abnormal, but he cannot make the diagnosis all the time. He will let you know that there is a vitreous hemorrhage. It is mobile, not mobile. There is RD, there is internal limiting membrane detachment or choroidal detachment. But for you as a resident or ophthalmologist, the ultrasound skills is essential for all of you. With color Doppler imaging, sometimes is indicated. We used to do it here, and we have the machine, but we are not. It's not part of our workup, except in certain cases. And we are just based on the B scan, clinical examination, and MRI to evaluate cases with leukochoria. MRI is always far better than CT scan for leukocoria for many reasons. First, you didn't need to expose the patient to radiation. If you find the clue within the MRI, that's good. If you find that there is a need for the CT scan, sometimes the radiologist or the neuroradiologist will conduct the CT scan test at the same time. If he find, he will look at the images of the MRI. If he or she feels that there is a need to do the CT scan, they will do it while the patient is sedated or while the patient is still in the DID department. Please don't consider the fine needle aspiration at all. Patient without a clear diagnosis and appropriate diagnosis, try to avoid any intraocular surgery or fine needle aspiration. A few years ago, a patient was referred to us as a case of endogenous endophthalmitis, and patient was seen, he was born in the north, and the ophthalmologist saw the patient. He thought that this is just endogenous endophthalmitis, and they decided to take an AC tab, vitreous tab, and they inject the intravitreal antibiotic as a case of endogenous endophthalmitis. Luckily, the technician in the lab detected that there is malignant cell on the aspiration from the vitreous. For this reason, they went back and they examined the eye. The eye was not be able. They dilated the pupil of the other eye, and they found there is multiple retinoblastoma lesion. You should not make the diagnosis on one eye examination. Patient presented with masquerading presentation, please examine the second eye. It's not uncommon for ophthalmologists, they didn't examine the normal eye. They just examine the affected eye, and sometimes they ignore the other eye, presuming that it's normal vision and patient is normal. Please examine the second eye for all patients with leukocoria or presented to you for any eye problem. CT scan, try to avoid CT scan for patient with a leukocoria, except if it's indicated by the neuroradiologist, and he find that he couldn't make a diagnosis by the MRI, then he could do the CT scan. The differential diagnosis, first we have to put in our mind all patient, children presented to you in the AR, in the clinic, anywhere with leukocoria is RB until proven otherwise. Never underestimate retinoblastoma. The reason I'm telling you that, because I saw during my work at KKESH a lot of cases being misdiagnosed, and misdiagnosed by different level of specialty. Most of them, first patient, not missed by the resident. They are missed by the attending, by consultant. Patient being operated as a retinal detachment while they are retinoblastoma. Patient being operated as congenital cataract, and really it's congenital cataract, but they didn't examine the posterior pole. Patient was presented with aphakia and bilateral retinoblastoma. There was a cataract, but there is retinoblastoma the same. It's a coincidence. It's not part of the patient has a hereditary cataract, but at the same time he got germline mutation, where he ended with cataract and retinoblastoma. Patient presented with high IOP, ophthalmia, diagnosed as unilateral congenital glaucoma. Patient underwent glaucoma surgery. Finally, we find that the patient have extraocular extension through the glaucoma surgery. For this reason, please, this is a message I would like all of you to take it with you from this presentation. All children with leukocoria is retinoblastoma until proven otherwise. I know there is a lot of diagnoses will be considered, but at the same time, please rule out retinoblastoma. Don't miss it, because it is, if you miss it, it will be a problem. A patient presented to KKESH just 2 years ago was considered as non-operable retinal detachment. Seen by retina, seen by two pediatric ophthalmologists, discharged from the system as a case of non-operable retinal detachment. Patient presented to us just 6 months later with metastasis in the spine, the brain, everywhere. Unfortunately, the patient deceased, and we couldn't identify why the family didn't come back, but it was misdiagnosed at KKESH. The same is happening from King Abdulaziz, same happening from other medical care provider. Not blaming the physician, but I'm trying to give a message for all of you. Please consider retinoblastoma. Don't take it lightly. Congenital cataract is just like it's vision-threatening diagnosis, and congenital cataract very easily to be diagnosed if the posterior pole is normal, if there is a total cataract, or there was just minimal or moderate cataract, and you could see the posterior pole, but you need to do B-scan to be sure that there is no intraocular masses, no RD, no posterior pole abnormalities. Pseudoretinoblastoma is a group of diagnoses that will go through them. And there's most of these pseudoretinoblastoma, I mean, it will not cause a problem for us. But it's not unusual to have a patient with pseudoretinoblastoma and retinoblastoma at the same time. What I mean, you may have a patient with retinopathy prematurity and retinoblastoma. You may have a patient with persistent primary BHPV and retinoblastoma. We have cases with retinopathy of prematurity with bilateral retinoblastoma. We have cases with BHPV and unilateral retinoblastoma. For this reason, I mean, just this week we saw a patient diagnosed with BHPV, and we didn't discharge the patient from the system. I saw the patient early, and I found that it is 100% BHPV. But at the same time, when we did B-scan, just last Sunday, we find that the B-scan is not the same as before. For this reason, we cannot discharge the patient. We are going to see the patient in 6 to 8 weeks to be sure that we didn't miss the diagnosis. BHPV, retinal vasculature anomalies with lipid Coats disease, toxic retinopathy, retinal dysplasia, inflammatory condition, trauma and neoplasia, plastic and proliferative lesions. The pseudoretinoblastoma, we could say that the first and the most common cause for pseudoretinoblastoma is persistent hyperplastic primary vitreous. The second is retinopathy prematurity, posterior cataract, coloboma. Coloboma, sometimes we think that it's not being misdiagnosed easily, and fortunately I was called by one of the residents a few years ago, and they are telling me that there is a patient with multiple retinoblastoma on both eyes. And when I went there, I found there is bilateral coloboma. I mean, it's not one coloboma, 2 coloboma in each eye. And I told him this is a coloboma, and he was surprised. But few months later, he rotated with me, and they discovered that his stereo acuity is 0. He has stereo, he's blind, and he's not seeing in one eye. And he was a resident with us. But this system was not, I mean, we didn't, a few years ago, there was no appropriate examination for the resident. But for all of you now, we expect all of you have good vision and good stereo acuity. The stereo acuity will help you to identify the the lesion in the posterior pole. With monocular, sometimes very difficult to know the height, depth of the lesion in the posterior pole. Posterior cataract, coloboma, uveitis, larval granulomatosis, congenital retinal folds, Coats disease, vitreous hemorrhage, retinal dysplasia. All these could be presented as pseudoretinoblastoma. For this reason, you should consider these things, but you should not give them the priority. You should put the priority for the retinoblastoma and congenital cataract. There are cases presented to you with leukocoria and unilateral cases like a trauma. Patient may present with a trauma. And when patient present with a trauma, could we have patient with a trauma and retinoblastoma or no? Okay. I have one patient who sustained trauma, ended with congenital, with traumatic cataract, operated at King Abdulaziz University Hospital, did very well, pseudophakic, discharged from the system, seen by a pediatric ophthalmologist in Qasim, referred to us as retinoblastoma in the pseudophakic eye. For this reason, it's not uncommon to find these rare cases. Vitreous hemorrhage usually is unilateral, but you may have patients with bilateral vitreous hemorrhage, especially with birth difficulties. Persistent hyperplastic primary vitreous, I mean, you could say 90% it's unilateral. There are some cases may present with bilateral presentation, but they are rare. Coats disease, medulloepithelioma and larvae. Retinopathy of prematurity is bilateral cases. Trisomy 13 is bilateral. VHL angiomatosis is bilateral. Nori disease, bilateral. Incontinent pigmentia and extended retinoschisis. Usually these are bilateral cases, may present with leukocoria. If we try to compare between how to differentiate between persistent hyperplastic primary vitreous and RB, usually there is no hereditary in VHPV, 90% is unilateral, microphthalmia, cataract, maybe there is segmental cataract just or little cataract or in the posterior, but sometimes they may present with total cataract, microphakia, I mean elongated ciliary bodies in severe cases. Some cases may not present with elongated ciliary bodies. Early retrolental mass, and rarely you have calcification, but sometimes with time they may have the fold, may have some collection, and may have some calcification. For this reason, if you find calcification with VHPV, it's rare, but it may have it. While in the retinoblastoma, usually may have negative or positive family history. 40% is bilateral cases. Rare to have a cataract. It's unusual to have patient with cataract and retinoblastoma, but it may have it. Microphthalmia is not common. Sometimes you may find with retinoblastoma megalocornea when there is advanced disease. And elongated ciliary body is not a part of the retinoblastoma. Early presentation is not uncommon, but usually they present a bit late, not in the first month. 95% is calcification. With ultrasound, 86 or 85% of patients you could detect the calcification. 15% of retinoblastoma may not have calcification. For this reason, absence of calcification doesn't mean this is not a case of retinoblastoma. These are two slides. You could see them on the left side and the right side. I mean, the right side, you could see that this is bilateral retinoblastoma, while on the left side there is total cataract due to rhizomelic chondrodysplasia punctata, dysmorphic chondrodysplasia punctata, and this is a syndrome where the patient presents with short arms and short lower limbs, and midfacial hypoplasia and mental retardation. Sometimes these kids may die in the first 5 years, but with medical care, and sometimes they may live longer. And this is just a congenital cataract, where the right side is bilateral. This is ended with bilateral enucleation. And he and his father presented to me just a few months requesting a letter because they would like to get financial support, and he was getting married. For this reason, I'm going to now follow his family to be sure that his kids received appropriate care, because I'm expecting that his kids will have the disease. 50% of them will have the disease. And he's just get married. His father invited me, but unfortunately I couldn't attend. This is a slide where you could see that there is leukocoria and segmental cataract. This is a case of didn't know if there is a laser pointer here or not. And you could see cataract. This is unusual and rare. This is a child with, you could see that there is synechiae in this slide. And you could see that the iris looks a little bit red due to iris neovascularization, which is uncommon. The B scan also shows that there is intraocular finding compatible with retinoblastoma. Cellulitis-like picture. Patient presented with cellulitis-like picture is not uncommon to see a patient with cellulitis-like picture, and this is maybe good for oculoplasty fellows. I have a patient who is presented to us, was seen in Jeddah and Mecca, admitted twice where he received IV antibiotic as a case of cellulitis. And fortunately, patient presented to us just maybe 9 months after his first presentation to the treating physician in Mecca and Jeddah. And he has orbital, preauricular, and intracranial metastasis. I mean, please, once you have a patient with cellulitis-like picture, consider that, be sure that the examination, put some topical anesthesia, put a speculum, examine the anterior segment, look at the fundus, regardless of the child, his cry or the family, they refuse, try to have good examination. And examine the other eye. Be sure that the other eye is normal. It's not uncommon. Once patient presented with cellulitis-like picture, and it's a case of infarction. Once there's a severe infarction within the tumor and the intraocular space, patient will end it with cellulitis-like picture. Sometimes the tumor is invading the optic nerve, and the optic nerve obliterated. Once the optic nerve obliterated, there is a chemical process within the intraocular space, and this will give severe injury of the eye and will end it with cellulitis-like picture. For this reason, try not to ignore the examination of patient presented with cellulitis-like picture. Examine the eye, be sure that the anterior segment looks okay, dilate the patient, look at the fundus, request B-scan. Don't just jump, admit the patient and start IV antibiotic. Patient with cellulitis-like picture, they will not need antibiotic. We usually give them just IV steroid for a few days and everything will subside. This is a patient presented with, you could see the preauricular lymph node due to the metastasis from the intraocular severity of the disease on the right eye. And you could see the seeds, this is the cross-section, and this is the imaging where you could see the calcification. Unfortunately, this child passed away and because of his late presentation. This is a case of leukocoria. The histopathology is just retinoblastoma where there's floret and flexor intestinal or rosettes, and you have to be familiar with the histopathology of the retinoblastoma. I mean, Dr. Azza Maktabi is always keen to teach any one of you who is interested to see cases of retinoblastoma, and she's doing a great job in this regard. This is a patient presented with bilateral leukocoria when she was 2 years, ended with enucleation of both eyes. And you could see the optic nerve was invaded, and you could see that it is invaded. And we have just a patient last week or 2 weeks ago. We enucleate the patient, and we find that the optic nerve invaded by 9 millimeter. But always I try to cut not less than 15 millimeter of the optic nerve when there is MRI indication that there is optic nerve invasion. And it's my routine to obtain at least not less than 15 millimeter of the optic nerve. This child is still alive, and she gets married, and she's with us in the system. She has 4 kids, 2 of her kids affected, and 3 of her kids affected, and 1 child is not affected. And all of her kids have 20/20 vision because we caught them very early. We treated them. They have multiple small lesions, treated with just the transpupillary thermotherapy. There was no indication to give chemo or anything. And all of her kids now, they have normal vision in spite of multiple chorioretinal scar and bilateral in both eyes. International classification, you have to be familiar with it. And each one of you expected to know what is the international classification. It's classified to 5 group A, B, C, D, E, and it is a very common question on the oral exam. Okay, when we speak about the anterior segment, finding in some cases of leukocoria due to the persistence of hyperplastic primary vitreous, you could see that there is a lot of ciliary bodies processes. And if you could see that the slide, the B scan, there's globe is small. And if you do a B scan, you will find that the stalk between the optic nerve and the anterior segment or the posterior wall of the surface, you could see the blood vessels. Not all cases with BHPV will end with this presentation, the middle. If you look at the slide in the middle, you will see that the lens is calcified now, resorbed, and with blood vessels. If you need to see how it's happening, patient will present with this one. The lens maybe have some cataracts. It may get swollen, and ended with secondary glaucoma. It will cause pupillary block glaucoma. Patient will present to you with pain and swollen lens, shallow AC. With a few weeks later or months, the lens will be resorbed and ended with calcified, resorbed cataractus or membranous lens. And sometimes these cases may end with physical changes, and with time, patient may end with calcification. And if the patient presented to you late, and if you do B scan, you will find a lot of calcification, and they may think that this is something serious and malignant. Well, it's the history will guide you to that. This is just a BHPV. It's not uncommon that we enucleate cases ended for us that as BHPV or CODS, but it's for us, it's more safe to enucleate non-seeing eye rather than just to observe and end it with unwanted finding. This is a case of CODS, and you could see from the slide in the round there, there's a lot of telangiectatic vessels, and the solution from the subretinal fluid, you could see the crystals, cholesterol crystals. If you look at this with a slit lamp with high magnification to the subretinal space for patient with CODS, sometimes you may see the floating cholesterol crystal. Sometimes. I used to see them in few patients, but if you look at carefully, and you will see this crystal floating in the subretinal fluids with portable slit lamp. And this patient now is just usually we treat them with retina. We'll send them to the retina where they do sometimes intravitreal injection and try to control the telangiectatic process in the retinal blood vessels. Incontinentia pigmenti, it's not, common disease, but you have to be familiar with it. Usually they're presented with a lot of oxidative retinal detachment and subretinal changes, subretinal fibrosis, and it's usually bilateral. And you have to be sure that to examine the whole body, to look at the teeth. There was a lot of slides but to guide you to make the diagnosis, but because these pictures are not sometimes good, I didn't put them in the slide. But if you look at the skin of the body, you will find there's some pigmentation, teeth, fingers, nails, hair, and usually there's sometimes family history. Nori disease, you have to be familiar that there is some patient may presented with Nori disease, and usually they are blind with cataract, sometimes retinal dysplasia and retinal detachment. And you have to be familiar that this is one of the diagnoses and differential diagnoses. For the Nori disease and for incontinent pigmenti, usually the treatment is not worthy. Sometimes these patients will end up with blindness regardless of any intervention. Let's see and look at these slides. For the right eye, for this slide, the one that has the number 17, what do you think the cause? This one, the first one near to me, is just its case of a trauma. This is commercial retina, severe trauma, and ended with the middle one. This is a clear toxo. And the last one, كيف؟ ما أسمعكم زراي. This is just larval granulomatosis. Yeah, for this reason, there is a lot of chorioretinal scar may present with different presentation, but you have to think in the proper way and you will reach the diagnosis. Diagnosis is medullobethelioma, that's a teratoma. It's not uncommon to have patients with teratoma. You are still seeing cases with medullobethelioma. How could you differentiate between them? Usually they have more anteriorly masses, and when you do B scan, you will find the cystic changes within the ciliary body. Once you have the cystic changes by B scan, 100% this is a case of medullobethelioma. You may have a patient with medullobethelioma and pseudohypopion. What I mean by pseudohypopion, you will find a lot of cell floating in the anterior chamber, what's the difference between pseudohypopian and real hypopian? There are three situations where you may have patients with pseudohypopian. The pseudohypopian, there is no inflammation, no synechia, no KBs, and it's not inflammatory. These cases could happen with retinoblastoma. You may have patients with a lot of spillover from the posterior pole where they ended with a lot of floating RB cells in the anterior chamber and may cause some leveling. And there is no KBs, no synechia because of the pseudohypopian. The same it could happen with medullopithelioma, and this could happen with leukemia. I saw cases with leukemia where there is pseudohypopian. The anterior segment is totally quiet. And once the patient received chemotherapy, everything is clearing up. This is just optic nerve anomalies and glory morning syndrome, or the optic nerve anomaly. Okay, this B scan will go through them one by one. If we look at the first one on the top on the right, what do you think it has? And again, the B scan, very simple. For the one in the top on the right, I mean, it is normal. Normal B scan, there is nothing, you couldn't see anything. The one on the left, on the top, it is just vitreous hemorrhage. The one on the right, down, it's retinoblastoma. The one on the left, it's HPV. But it is very straightforward finding. I mean, it's not. Let's see these ones. Here we could see that there is internal, limiting membrane vitreous detachment. And you could see that there is, if you look at the B scan, you'll see that the A scan is very high. This means, is it a vitreous detachment or it says RD? RD. On the other side, there was just a dense vitreous hemorrhage, and here you could see the retinopathy prematurity. The lower one is retinopathy prematurity on the left side. This is what we call color Doppler imaging. We used to do it for our patient. There was a study, we tried to find a way to, and we could find that there is a lot of finding with retinopathy, with the color Doppler imaging. It was very difficult to move the machine to the main OR and time consuming for the season we are. It's not part of our routine workup. You'll see that there is the slide, and you can see the slide on the other side. I mean, it's clear, compatible. If you look at the slide, that DID, color Doppler imaging, and the histopathology slide or cross section, it's compatible exactly with the same finding. The same in this case, you could see that there is a totally filled with tumor. And if you look at the slide of the optic nerve there, it's obliterated optic nerve. And if you look at the slide, the color Doppler imaging in the middle down, there is no perfusion. I mean, there is no blood perfusion. This is compatible with total optic nerve obliteration by the tumor. Once the optic nerve is obliterated or the blood supply of the central arteries is affected, patient will end up easily with iris neovascularization and may present with cellulitis-like picture. The same, this is color Doppler imaging, and you can see that is trying to present this slide to show you, to compare the DID finding, the color Doppler imaging, and the histopathology finding. They are compatible with each other. In summary, I would like to stress that all patients with leukocoria should be considered as retinoblastoma until proven otherwise. And you have to be sure not to do any intraocular surgery without B scan. It's not uncommon to see congenital glaucoma patient went for glaucoma surgery without B scan. And it's not uncommon to see patient with congenital cataract who will go to the surgery for lens aspiration and vitrectomy without B scan. Please consider B scan for any intraocular surgery. And consider all patients with leukocoria or children with any ocular abnormalities that they may have retinoblastoma, and don't miss them. Thank you very much. If you have any question, please, let's go through them. فاهمين شكلكم مرة. ما في أي سؤال؟ يلا سلام عليكم. شكلكم صايمين مرة. احنا ترى نبي من الجراجويت الريزيدنت نبغى نبتعثهم اللي عنده استعداد منكم. ocular oncology, uveitis, neuroophthalmology. ما ينقبل الريزيدنت اللي يخلص من ما ينقبل الريزيدنت عنده قبول برا.
And can we take out this? Because sometimes you're not originally able to work. Apple. Look, as well. It works perfect. So this is your laptop. You are okay. Okay. And you have the part.
Good afternoon, everybody. Assalamu alaikum. It is my pleasure to introduce my colleague, Dr. Diego Strianesi. He is original from the University of Naples, Italy. He is a member of the Orbital Society. He is the head of the Orbit Division in KKESH. He had several articles and books published. He has a large experience in orbit, and he will talk for us one subject that he is very familiar, and it's my pleasure to have Dr. Strianesi here talking about the update on management of thyroid eye disease.
Thank you, Dr. Silvana. So today we try to define what is thyroid eye disease, because I know that everybody here in the audience certainly know what we are talking about, but speak briefly about definition. Many of you still call Graves' ophthalmopathy or thyroid-associated ophthalmopathy. Let's say that there are several names for this disease, but I would suggest on current evidence, a current agreement, to define this disease as just thyroid eye disease, TED. It's much easy and better, and now the international communication is with these terms. Historically, very briefly, it's interesting to note that the first time that has been described was in the 12th century. Actually, I think in the this was a fellow of Avicenna, famous doctor, and after 5 centuries, there was the official introduction in medicine of this disease. It was first really recognized and described. As you see, the first description was the association. Of course, Said Ismail al-Jurani, he didn't know about thyroid. He just described the association between proptosis and goiter. And then, after 5 centuries, almost at the same time, 4 different physicians described this disease. And the most accurate, for this reason, for a long time we have used it to call this disease Graves' disease, because the most accurate description was done by Graves, Robert James Graves. This was the first description and that you can see in the book of Bazedov. And as you can see, he described that a lady that he called Madame G had this proptosis, and she was absolutely healthy, he defined. So that was the first things that they noticed. How can it be that a patient has these eyes, but generally it probably is healthy? Epidemiology, so I see that this is the only prospective study that has actually reviewed a single population in attempt to find the exact incidence of this disease. And as you can see here, there is a wide differences in between men and women. Women are definitely much higher, there is a much higher incidence in the women population, at least 4 or sometimes 5 times more than men. But I would say, and this is the first concept that you keep in your mind that, as a take-home message, that in men usually it's worse than women, although it's rarer. And that is also very important. Why? So how many patients with thyroid problems they develop thyroid eye disease? So if you look at the literature, you will see that there are something like 5% or some reports that say 15%, or some reports that say up to 50%. And there is the explanation is very easy. If you want to look at the patients that have clinical symptoms of thyroid eye disease, so the percentage is quite low, it's up to 10 to 15%. But if we check all the patients of a defined population with the thyroid problems, you will see that if we check with ultrasound or CT scan, or even better with MRI, you will see that the population rise, the number of patients who have some signs and symptoms of thyroid eye disease goes up, even to 50%. So the modern definition of this disease is that it's an inflammatory process that involves mainly the connective tissue with the remodeling of orbital tissue and with the result of a deep changing in ophthalmic and orbital structures. This autoimmune disease with the high variable natural history and broad range of clinical manifestation. So normally, thyroid eye disease is high associated with thyroid problems, with hyperthyroidism. But if a patient has thyroid eye signs and symptoms without thyroid problems, it does not necessarily mean that he doesn't have thyroid eye disease. So keep in your mind that patients with thyroid eye disease can be hypothyroid or can be even euthyroid. No problem at all, as was in the first description of Graves. So speaking about pathogenesis, because I was supposed to give you some information about management, but it's very important nowadays to understand that the new management for this disease comes from the new achievement in knowledge, in understanding of the pathogenesis. We have different views to describe the thyroid eye disease, and we can see that there are even some different patterns of the thyroid eye disease depending on what we consider. For example, if we want to say a macroscopic view, we will see that the macroscopic view is that thyroid eye disease depends on a discrepancy, a mechanical discrepancy between the increased volume of the swollen orbital tissue and the fixed volume of the bone. So basically what we have an increased volume of the intraorbital structure that cannot be fitted in the orbital bone. But we can have enlargement of the orbital extraocular muscles, but we can have also increase of the volume of the fat. So you can say volume of fat, of increase of volume of the extraocular muscle. So nowadays, we used to say that we have type 1 thyroid eye disease, which means that we have those patients, sometimes with the quite severe disease, who have increase of orbital volume of the extraocular muscle and increase of the orbital fat. This is called type 1. They are both enlarged, both involved, fat and muscle. We can have type 2, means that basically they have big muscle belly, big increase in volume of the extraocular muscle. And we can have type 3 with fat predominance, with a lot of fat, increase of fat. So this is very important, because to address especially the surgery or the decompression, we should know, I would say we must know, what kind of patient we are facing on. To better define, we developed in Naples a MRI procedure which can help in define specifically if there is a orbital volume increase or if there is a muscle increase of volume. And you can see that correlates well with grade of proptosis. Now, this was the macroscopic view. Let's see now what is the intermediate view. What does it mean? The intermediate view to me, it's the pathological findings. You can see here increase of some connective tissue, particularly fat, or you can see here an increase of volume. Be careful, not number. Increase of volume of the muscle cells. So it's only what we know now, which is very important because the last achievement of the therapy that we have comes from the knowledge of this issue, that thyroid eye disease is mainly a disease of the retroorbital fibroblast. So fibroblasts of the orbit can differentiate, can switch to produce adipocyte, that can switch to be adipocyte, and so they increase the volume of the fat, or they can go in between the muscles and increase the volume of the extraocular muscle. So let's see now what is the microscopic view of this disease. If we have a change of the fibroblasts, if the fibroblasts turn in different cells, which is the target? Which one is the receptor? Which one is the pathogenical cascade that leads to these changes in tissue? We, in Naples, we were one of the first group that recognized that the role of the TSH receptor is a key point of the developing of the thyroid eye disease. And further study have shown the same results. So far, we know that the TSH receptor expressed in retroorbital fibroblasts is one of the key of the pathogenesis of this disease. And because specifically it can activate and it can, because there are autoimmune IgG that can directly activate the TSH receptor in the retroorbital fat. But nowadays, and more recently, we know that a key factor is not only the TSH. That's what the idea was. Many researchers, they were wondering, okay, if is the TSH receptor expressed in the retroorbital fat, why only the orbit is so involved in Graves' disease? Because TSH receptor can be expressed even in other parts of the body, even in other anatomical districts. Why only in the orbit is so, it can cause all these changes? And the fact is that we recently found that also IGF-1, which is the insulin-like growth factor receptor, can play an important role in this disease. And this recently was also the target of a new medication that later on I will discuss with you. So just to make very simple, now we know that probably there is an activation of B cells that can produce some autoantibody that can activate together, that probably they work together, the TSH receptor and EGF-1 receptor, and they can activate the orbital pre-adipocyte, and also with the help of the T cell, and producing and causing inflammation, but at the same time, with a different pathway, they can induce adipogenesis, inflammation, and hyaluronic acid accumulation. So we know that now these two are the key of the pathogenic cascade of thyroid eye disease. Okay, let's see now something that probably for you will be more interesting, which are, we know that from clinical, and so that I define microscopic view, there are some causes that can increase the risk or can make the disease worse, some risk factors. One of the well-recognized factors is the cigarette smoking. So the first things that I normally, and we all normally ask to the patients when they come from the first visit is to quit smoking, or at least to reduce dramatically, because other than and you know that in United States, some insurance, they don't cover the medication for the patient unless they quit smoking. So, because we know that whatever we can give to those patients, if they don't quit smoking, if they don't reduce the number of cigarettes per day, no medication will be, the success of medication will be very, very low. And there is another thing that we cannot do anything. We know that can make the disease worse. We know that can be a risk factor, which is the treatment with iodine radioactivation. So you know that in Graves' disease, sometimes the endocrinologists, they cannot handle the patient just with the oral medication, so they have to decide between surgery and radioiodine activation. And we know that iodine probably works better, but can make worse the thyroid eye disease. And we know that probably because of the release of because it resulted in a depletion of the cells and in cytolysis, which probably increase the number and the amount of autoantibody. So this probably is one of the explanations why the thyroid eye disease can become worse after this treatment. There is also another evidence that we described, which is very also interesting, and you should make a patient aware about that. Sometimes you have one patient with unilateral proptosis, then you can probably treat first with the steroids, and then you give, then after that you can do decompression because steroids is not enough. And okay, the patient is fine, probably is happy, and like after 6 months, up to 5 years, he can develop a contralateral proptosis. And now is well known, and here we have many even anterior segment colleagues, that this may happen also after cataract surgery. And so patients with the thyroid eye disease who had already a treatment for unilateral proptosis, if you do cataract on the fellow eye, you have to just advise the patient that he can develop a new episodes of thyroid eye disease on the contralateral eye. And this, is, of course, is one of the main explanations that is an autoimmune disease. So it never really stops. Here, and you see that we were able to find that there is this association with surgery. Okay, so that's the important point. So now, knowing that this disease is quite complicated, we know very well now the pathogenesis of the disease, although we don't know exactly which one is the first step that led to this disease. So we can basically think that we can stop the disease in some way, or we can slow down the disease, acting on the autoimmune process with immunosuppression, or we can go now, we can be more specific, targeting the receptor that we know are involved in this disease. Or we can, and coming back to the microscopic that I said at the beginning, we can act only on the mechanical part of this disease. So if we do decompression, if we perform a decompression, we basically resolve the problem of the mechanical problem. So we basically try to enlarge the volume of the sockets in order to fit the enlarged volume. And now I show you some patients, because I want, because it's quite often, and allow me to say very often, or probably too often, I heard that people ask, so doctor, should we start with the steroids? So, of course, everybody knows that steroids work in thyroid eye disease. But you should know that steroids, there is a precise and accurate indication for steroids. You cannot give steroids to all patients with thyroid eye disease. It can cause very bad side effects without any benefit for the patient. We now have very clear guidelines when everything should be started. So this means that you should know, if you want to handle and manage those patients, you should know when you have to do nothing, when you have to give steroids or other immunosuppressive medication that we have nowadays, when you can give or prescribe for him radiotherapy, and when you have to do surgeries. So it's absolutely a very difficult and complex process to assess those patients. So these patients need something different for sure, and from this other one, or from this that also has a very severe proptosis, but doesn't need steroids at all, for sure. And even this patient, we should know that we have 3 different grades of severity. So we have mild disease, moderate disease, and we have severe disease. Another tip very important is that we have to know that the activity of the disease, which means an attempt to measure the inflammation, is the main indicator if we can give to the patient steroids or immunosuppressive therapy. And also we should know that this disease can be vision threatening, and there are some urgent patients that should be treated urgently. And those patients are those who have compressive neuropathy or who has corneal exposure. Traditionally, we know that we used to say, there is the Randall curve, so we know that we have this curve that described all patients. But let me tell you something. This curve, it's very useful, no question about that, because describe that there is a first part of the disease that has mainly is characterized by inflammatory signs, and there is a second part that is mainly that is the sequels of the inflammatory process with the fibrotic process. But this is not actually true, because you should know that although Randall did a great job in describing this curve, these curves comes from the description of only 1, 2, 3, 4, and basically it's only of 5 patients. So he took probably like 5 or 6 patients, and he followed those patients for several months. And finally, he saw that they were probably, they had the same course, and he described this curve. But nowadays, we know that probably this curve can fit the majority of the patients, but not all the patients with the thyroid eye disease. This was another big achievement that I think all you in the audience, you probably heard about it. That was when Professor Moritz introduced the clinical activity score. So he found the signs and symptoms that can describe properly the inflammation of the disease. Since that time, anyway, we use this score, and also there was reported in EUGOGO, the European Association for the Study of the Thyroid, as the mainstay to describe this disease. However, there is another society, that's the society which I belong to, and I'm chair now. It's the ITEDS, the International Thyroid Eye Disease, that we start wondering, okay, the clinical activity score basically described only the inflammatory sign. But as I said, for this reason, I'm sorry that probably for you was not very exciting, but I introduced at the beginning the description of the disease. We cannot say, if we give a medication to the patient, okay, just to make clear, and we give steroids, the patient feels better, but is still not very happy. Forget that many patients, especially thyroid eye patients, they are never happy with any medication or whatever you do. But anyway, they are not happy because most of the mechanical symptoms, they are not resolved. And they are not resolved because the disease is also a mechanical disease. It's not only an inflammatory disease. So thyroid eye disease is not only an inflammatory disease. It's also, as I show you, a mechanical disease. So what we did is basically to see in this study that came this year, we published this year, after 2 years of a multicentric study where we follow many patients, we found the actual and reliable signs to describe a patient, the activity of a patient. And we found that the most important one are the edema of the conjunctiva, the redness of the conjunctiva, and the edema of the eyelid, and the redness of the eyelid, but not the caruncular edema, which was included in the first description of Professor Moritz. And also the redness, the superior conjunctival redness, is also not reliable. And it was also included in the clinical activity score reported by the EUGOGO. So briefly, I would show you what we are talking about. So when you face a patient with a thyroid eye disease, let's see, first of all, which is the chemosis. We have 2 grades of chemosis. The chemosis is just this edema that you can see here in conjunction with conjunctiva and eyelid at the border of the eyelid. And it can be on the gray, if it's behind the gray line is grade 1 chemosis. If it's over the gray line is grade 2. What is the conjunctiva hyperemia? Is this one and not confused with other kind of signs. This is also a patient with conjunctival edema. That's what I was talking about. Don't confund with this one, which is not the redness, but this is congestion. So you cannot classify this as redness of the conjunctiva. This is congestion of the conjunctiva. And this is the redness that we considered in the thyroid eye disease. This is the redness of the eyelid, and this is the edema. You see the skin is tense and is exactly pre-septal edema. So not confound with this one, which is fat prolapse. This is very important when you assess a patient. Because when we have to decide if we give or not steroids, we have to recognize those signs. No way. You cannot give steroids if you don't report exactly 0 or 1, which means present or not, those signs that I have shown now. This is very, very important. In fact, if we have to fill a paper like this, and then we finally, if the score is greater than 4, so we can give to that patient steroids or immunosuppressive therapy, whatever, but you are allowed to give. But if you don't feel exactly, if you don't assess the patient properly, you are not allowed to give any medication as long as you don't do this. So it's very important to find also after you assess the activity, you have to assess if there is any visual problem, which I said it's an urgent problem in thyroid eye disease, if there is diplopia, and if there is restriction of the movement, and if there is a severe appearance of the disease. Of course, you have to take measurement of apoptosis, and as I said, you have to assess all the visual function, which means not only visual acuity, it means also the pupillar reflex, the color test, and the visual field, which to me it's also very, very important. And sometimes you need to ask for a CT scan. Not only patients have, when there is any possible problems to the visual function, ask for a CT scan. It's the only exam that show you exactly the crowded apex syndrome, as you can see here. So the compression of the optic nerve due to the big belly of the extraocular muscle. This is an emergency. And you have to treat this patient, otherwise he will lose vision. No way. So a second, very important, this is, I think, our colleagues of the anterior segment are very interested in this, it's the ocular surface damage. The corneal breakdown in patients with Graves' disease can be a disaster because they develop very easily deep corneal breakdown. They can have serious complication of the cornea because they also, at the same time, they don't have only exposure, mechanical exposure due to the lag of thalamus, due to the eyelid retraction. They have also lack of the tears, because in the autoimmune process involve also the lacrimal gland, and they have at the same time also some weakness of the sensitive nerve, because it's also involved in the inflammatory process. So, and this is the way how to assess the motility. It's very handy and simple. You can just see the corneal reflex and have just an idea before to send to the PIDs. Normally, honestly, I manage by myself in my country the strabismus, the squint surgery in Graves' disease. But anyway, here it's the rule is to send to the pediatrics, which is fine. But just to feel and to have an idea, this patient you can see easily as a deviation of the left eye in upgates, and you can see that the deviation in Graves' disease, of course, should know that it's due to the restriction and not to any paralysis of the muscle. You can take a measurement of the intrapalpebral fascial and MRID just to have to make clear the eyelid retraction, and with the purposes also, if you want to know if you have done something good or wrong, you have to know how many millimeters the patient has of retraction. You cannot say this patient presenting with eyelid retraction. This is very general terms. You have to know, you should know, and you have to say how many millimeters of eyelid retraction. And you can describe this using the MRID. Then you have to assess the fat prolapse, so that I said is something different from the edema, you see, and in Graves' disease is very common. There is no edema, this is fat prolapse with some inflammation, and this is the kind of edema, which is totally different. Edema is, if you do surgery for a patient like this, it's a big mistake. This patient does not need surgery immediately. This patient has this puffiness of the eyelid because of the inflammation and not because of the fat prolapse. So coming back to what I said at the beginning, now we have an idea how to assess the patient. We have a patient with mild disease, moderate disease, and severe disease. Patients with mild disease are patients who have, they have some, you see, not sign of very active disease. They sometimes have ocular surface symptoms. They have foreign body sensation because of the minimal exposure. And they sometimes, so what we can suggest to those patients is to quit smoking, to go to the endocrinologist to try to fix their thyroid. However, what we want to prevent in those patients? We want to prevent in this patient that they progress from mild disease to moderate to severe disease. How we can stop this? First of all, is good things to give them lubricants. Lubricants are very useful, not just to please the patient. The patient wants lubricants, we will give him. No, lubricants in this case can, there are many papers that have shown this, that lubricants in those patients can in some way minimize the trigger of the inflammation, keeping the corneal surface in a good, in a healthy situation. Normally, this patient, as you can see, this should be all the things that we have to assess and feel before to treat a patient. You see, it's a lot of things, but only once we have filled all this paper, we know what we can do for Graves' patient, for thyroid patient. So this patient has a problem mainly with ocular surface. Another important topic is not only to assess the patient to the first visit. Thyroid eye disease is a very dynamic and progressive disease. Patients with thyroid eye disease, thyroid eye disease, they can change over the time. So very important is to feel exactly all the paper sheet that I've shown, and after 3 months, repeat again all the assessment and see if there are any changes. But more important is also to ask to the patients the quality of life. Because the quality of life nowadays is accepted worldwide as one of the indications for therapy. It's not only what we see and what we can assess with the clinical, with the imaging, is also the quality of life. And I will show you why. So this is an example how a patient with mild disease can progress to a severe disease in 1 year. if we don't start to give him lubricants, if we don't ask him to quit smoking, if we don't ask him to go to the endocrinologist, he will progress. And he will progress even sometimes badly. So there is also another study, another new evidence, and now I start to give you some information about the new treatment, that probably in a patient with a mild disease, we can prevent the progression of the disease, giving selenium. Selenium, it's not a proper drug. It's a supplement and is an antioxidant. Many studies, or few studies, but very well conducted, prospective study, has shown that the selenium can prevent the progression of the disease. However, there are some concerns. Selenium, because the diabetes, it's an issue, and probably we have to be careful in giving selenium. What I suggest is that a patient can have a blood test and see there is a clear report that if the blood test of selenium is below a certain level, you can give to the patient selenium. But if it's a normal range or is above the normal range, don't prescribe selenium to those patients. Now we go to the key part of the speech, is that what we have to do with the patient with the moderate disease. Patients with moderate disease, as I said, are patients who have not threatening of the vision, but they have sufficient impact on their daily life, so to justify the treatment. Those patients cannot live, they don't have a good quality of life. Their life is sometimes is miserable because they have, you can imagine what does it mean for a patient waking up in the morning, looking at the mirror and see like another person. It's psychologically it's dramatic. It's a terrible event. So very frustrating event. So those patients, you see, normally have very bad quality of life. So we have to give something to this patient. We have to do something for this patient. There is no way. Everybody worldwide is agree. So you can be comfortable in starting with some medication. Of course, the well-known, the mainstay is still steroids. And we all know that we normally give steroids 500 milligrams a week for 4 to up to 6 weeks. And IV steroids now, everybody prefer, including me, to give IV steroids instead to oral steroids, because oral steroids seems that they can give more side effects than IV steroids. There was a concern before about IV steroids that can be deathful because of acute liver failure. But as we show clearly, if you don't go above of the total dose of 8 grams, you are in the safe side for those patients. So don't go up to 8 grams. You can give IV steroids 6 weeks, 500 milligrams a week, and it's a well-recognized treatment. However, steroids are not the medication that you can give to all patients, because steroids can have a 20% of recurrence rate, and 7.5 anyway during the treatment can develop optic nerve compression. So it's very frustrating if you give steroids, which is also a very heavy treatment for the patient, to have some 20% of patients that develop a recurrence of disease. So you should have alternative treatment. And alternative treatment can be radiotherapy of the biological agent. Radiotherapy is very useful, but it's well known now that you can use radiotherapy when you have already used steroids. It can increase the effectiveness of the steroids and can prevent the relapse of the disease. We conducted a study in using the radiotherapy alone, and we see that radiotherapy, you can give radiotherapy alone in those patients that have contraindication for steroids. So if the patient is diabetic, if the patients have heart failure, those patients, it's better to treat with the radiotherapy rather than steroids. Nowadays, it's the new interest worldwide is the use in thyroid eye disease of the immunomodulator. And you can see that we have we have a bunch of drugs that can targeting several steps of the inflammatory cascade. And I think that many of you, even because they use in uveitis, or they use even some for other autoimmune disease, you have already heard about it. But which one is useful for thyroid eye disease? Rituximab hasn't been used and is the most widely used immunomodulator for thyroid eye disease. But what I want to show, you know that the target of the rituximab is the lymphocyte B, and particularly the CD20 receptor. And there was this famous study conducted in Italy that has been shown that rituximab is very effective in patients, is even more effective than steroids in patients with thyroid eye disease. And they report a very nice result in terms of reduction of the clinical activity score, as you can see here. However, some patients developed some decrease of vision after the infusion of the rituximab. And on the other hand, there is this other study, even on the rituximab, conducted in the United States at Mayo Clinic, in which the authors, they found that there is no result using this medication. And also, they found the same problem, that some patients develop optic neuropathy using rituximab. In the Italian study, which showed rituximab effectiveness, the patients were all treated in the early stage, while in the Mayo Clinic study, the patients were all treated in the late stage. So what does it mean? That you can use rituximab, but you have to use rituximab in the very early stage. If the patient has already 2 years history of thyroid disease, probably it's better to avoid this medication. Another treatment is the adalimumab. This looks good treatment because you can inject subcutaneously this drug. But honestly, if I have to say that I would suggest this treatment, no, because the only report that I found in literature didn't well address all the be careful in using that drug. Tocilizumab is also another well recognized and used immunosuppressive agent for Graves' disease. And it's interesting that this group found that is very useful in steroid-resistant patients. So probably this can be an alternative treatment in patients who became resistant to steroids. And they show, as you can see here, a decrease of the clinical activity score using this therapy. They also had some adverse effect. Mycophenolate is also another drug that have been used, And the results are also quite encouraging. As you can see here, there is these are the patients treated with the glucosteroids, and these are the patients treated with MMF, and you can see that probably we have more responder using that drug. Unfortunately, also they have a number of side effects using the mycophenolate medication. And now, just very briefly, I want to show you this novel treatment. The interesting things of this novel treatment, there is only one study that has been done so far, and is the teprotumumab. And this is a molecule that can targeting directly the insulin receptor. And very interesting that they, using this drug, they not only had a decrease of the clinical activity score. For the first time, with just a medication, they found that also the proptosis decreased. So, which means that if this result is true, we as a surgeon have stopped our job, because the patients using this medication don't need any orbital decompression. We will see in the future what happened. Just keep in mind that methotrexate is also a very useful alternative to steroids, especially in steroids resistant patient, and this was one my study. And there is also another study that recently has confirmed that methotrexate can be a useful alternative treatment to steroids. And finally, what we have to do in severe disease. In severe disease, everybody knows that the first treatment is the steroids. When you have patients with optic nerve compression, you have to treat those with steroids, with IV steroids in the attempt to save their vision. Sometimes patients don't respond to steroids, so you have to do decompression. And you do decompression, but decompression works in 50 up to 70% of cases. Sometimes you do decompression, you also repeat decompression, and they still have problems with vision. This is a patient treated in KKESH, and as you can see, this is the visual field. It was very, very bad. You see, this was almost blind in one eye. This patient had two courses of steroids. This patient had 2 times decompression, and still his visual field did not improve. But after the use of infliximab, we start infliximab, and after infliximab, patient starts to improve, and he had, you see, this acceptable result. And you remember that was almost blind. Anyway, his vision, he had the recovery of vision, you see here, that was acceptable in comparing to the blindness. I think that in 5 minutes I have to conclude, so I want to give you only some few messages. And remember that before to give steroids and start any medication, you have to assess properly the patient. Once you have to assess the patients properly and you are sure that you can give them steroids, immunosuppression, you have to check if steroids are working or not. If not, or if there is a recurrence of the patient became steroids dependent, you have a number of alternative treatment. I would say if the patients respond quite well to steroids, you can go for radiotherapy, or if you cannot give steroids, you can also use radiotherapy. Other than radiotherapy, probably you can use some of those medication, and particularly probably the new one if there are other evidence that comes to us. the last things that I want, you can find some other indication or contraindication of the new therapy in this article that you can find in recently in Current Opinion. I don't want just take a long time, but just to show you what does it mean decompression for thyroid eye disease. What I meant when I said sometimes you do decompression, it is not enough. This is the patient at the first decompression you see here. He got actually a little bit of decompression, a reasonable decompression. But when we did the second decompression, it was very wide. Look what we did. And he still was not responding. We took away all the lateral wall, the inferomedial, everything. It was still not enough. So sometimes patients with threatening of vision, they are very, very difficult to treat. Just a few words to say that the compression before was with the wide access. Now we tend to use a minimal invasive surgery in order to minimize any scar and also the morbidity of the patient, achieving a good result. And sometimes, as I said, it's very important to assess patient because patient with only enlargement of the fat volume needs only fat decompression, as I normally do. And I say I'm quite happy if I can take out for moderate proptosis like 2 or 3 cc of fat that I can measure. The last very quick procedure, but sometimes leading to very good result, especially if involve the upper eyelid. But if involve the lower eyelid, you can use several. You have to use to go against the gravity. You have to use some spacer. The take-home message is that sometimes we can achieve a very nice result. Patients are very happy. And but sometimes patients is also to accept that this patient who had steroids treatment, radiotherapy, decompression, eyelid and strabismus, squint surgery, they have also to accept that we cannot, and it's very important to speak with those patients and to because to make them understand that we cannot give exactly the same appearance that was before. Okay, thank you. Any question? Yes. Absolutely. You get, yes, in order to decrease the time, to shortening time, I didn't mention it. CT scan, it's very important, I said, because for two reasons. Because sometimes in emergency, it's easy to get the CT scan rather than the MRI. And second, because give you exactly the idea of the bone. When we have to plan the compression, I must know exactly the thickness of the bone, what I risk to avoid CFS leakage, and especially if I go inferomedial, because I have to go inferomedial. MRI is definitely much better in terms of assess the soft tissue, and also there are some evidence that MRI is very good also to assess the optic nerve itself. So you are right. If you can have both, much better. Yeah. It's a very good question, because that's what we were wondering last time, and I hope, Dr. Osama, as you know, that's probably even there is a open door that even KKESH can be involved in a second phase, that we both are trying to work on that. And that we'll see, because they didn't report any side effect, which is very uncommon, a little bit weird. But it's a big journal. It's the biggest main New England journalist. But you never know. So we hope that we will both involve in the second phase and see. And hopefully not for the patient that we won't see side effect. The teprotumumab. Teprotumumab. Okay. Thank you.
How this working? But I don't like to. Okay. Don't go. Stay here, please. Please. Yeah, I think. Let's see if we put it big screen. Yeah. 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 Okay. Vital. Thank you. Thank you very much. Ready to start, please? The fellow. Everything is going to be okay. I select only retinal case. I would like to put the light off, please. The main case is 45-year-old male, may complain blurred vision and OS. The diagnosis question is diagnosis, possible ocular complication, and treatment. Here you can see this patient was working as a Cape explorer and lived in the United States in endemic area. And here you can see optic nerve atrophy, some pushed out lesion, and macular scar in the right eye. Also in the left back. What about the diagnosis? Possible ocular complication related to this disease. Option treatment. Just 3 minutes, it's okay. It's better now. Again, look, the vitreous body is totally clean. Optic disc atrophy, macular lesion, and push-out lesion bilaterally. Dr. Darling was an American pathologist that he was working in Panama during the Panama Channel was building. He described this condition when he was trying to find leishmaniasis there in Panama. Okay, again. Ready? Remember, the patient was working as a Cape explorer and lived in the very specific area in the United States, endemic for these diseases.
Ready? All right, second. All right. 45 years, complaint, vision drop in both eyes. I would like to know, this is very, very strange ocular fundo. Look, a lot of retinal vessels. Okay? And this is a bilateral condition, as you can see here. The patient also have the lesion here in the macula. Look, a lot of retinal vessels. Then, bilateral. What about the diagnosis? If any systemic association, please, at least 2 or 3. What kind of complication? And what about the option treatment? If this complication like this is found, Doyne described this condition in the Royal Society in London in 1889. Oh, yes, please. Sorry. Diagnosis, if any systemic association, main complication of these diseases, and treatment. The complication is like this. Look, this is the retinal vessels. The complication usually appear after a minor trauma. It's a bilateral condition. Ready? One minute. Go for the next, please. Go for the next. Okay, 24-year female, main complaint visual loss of it. What about the diagnosis? Any special tests to confirm the problem? Main complication and treatment here. This is the bilateral. You can see here a yellow plaque and 2 superior inferior in the left eye. And this is the main complication, as you can see. What about the diagnosis? To confirm if the patient has, you order any special test. If this complication appear, how can you treat this? Oh, yes, please. One minute. It's okay. Next, please. Okay. It's very common here. 28 years. A main complaint: blurred vision, bilateral. It's bilateral. What about the diagnosis? What treatment as possible, as soon as possible, do you apply? What could happen if you don't apply this treatment in this patient? This is bilateral. Yeah. Oh, yes, please. When you see that this patient needs as soon as possible treatment, what about? If you don't apply the treatment, the patient has the risk for. So it's bilateral. Sorry, I can catch it. Of course. It's very common here. There? Oh, please. One minute. Next. Well, this patient has systemic hypertension, the vision dropout. What about the diagnosis? What test do you need to treat before this patient? Please. Got the problem here. This is the complication, but you need to confirm it. You need to order some tests, and then you have to treat what you find after perform the. The patient had a systemic hypertension. Ready? All the questions are related to the diagnosis, special tests, and treatment. You mean this? The left or the right? The right. Of course, the diagnosis. what kind of complication could appear? Like, is bilateral. This is a optic disc atrophy and push-out lesion and macular lesion, and the video is typically in this condition clear. Here, this is like this also have the same complication here. All right? Like this. Okay? Okay. Next. All right, this is the last question.